use of ultrasound in emergency or in a critical care unit, it's always for the benefit to rule out, certain diagnostic, differential diagnosis, or to see what's happening, what is the prognosis, or what will be the outcome of the patient. So generally, this talk would be focusing totally on what's the uses of ultrasound in the emergency department, and a little bit of example what we did during the COVID times, and how we how we incorporated ultrasound in our COVID management pathway. So hello everyone. Uh, so when we talk about focus, that is point of care ultrasound, so there are three different parameters, like what all things we can see via ultrasound on a patient body. It has to be definitely, because it should be bedside, and the machine should be mobile. The ease of transport from one patient to another patient should be there, and how we can, sterilize the equipment. All those things should be there. And then we will talk about the focus cardiac ultrasound, that is the 2D echo, which we do at the bedside, and the lung ultrasound. All these were used definitely during the COVID time. So in COVID-19, like in 2020 when it started, and then 2021, and then 2022, we saw the escalation of surge capacity, because of when the second wave came. It was quite huge, and there were a lot of patients who were needing differential diagnosis, or who were needing what next to be done. Okay, we have given medicines, we have given fluids, we have given antivirals, but what next? What could be the prognostication? How to prognosticate these patients? So that's where a focus, that is ultrasound usage of in COVID patients, was launched. When we talk about, okay, so ultrasound, we have x-ray imaging, we have CT scan. So is it comparable to chest x-ray? Is it comparable to CT scan of lung? So we'll discuss about that also. So definitely focus can help, and that is also point of care. We need not forget about our physical examination. Your stethoscope is mandatory, the auscultation needs to be done, the cardiac sounds needs to be heard. But these new intervention, these new diagnostic facilities are there to help us. Now, prior pandemics, like what were the
The
similarities and
slides
what
are
were
not changing.
uh, is it?
Yes, ma'am. It's
Because from
still
my
on the.
side it's
Yeah, now
changing.
it is changing. Yeah.
Yeah, yeah. So during the prior pandemics, like as you can see the pictorial representation of starting from bubonic plague, which was in 1347 and which lasted for 4 years till 1351. And then when we compare all these pandemics, so COVID, you can see very minutely it stands at the last when the coronavirus 1920 and it came. So when we see what is the difference and what were the similarities during this pandemic and the last pandemic, that was of H1N1 in 2009. So definitely avian influenza A, that is the S7H9 variant, in which happened in 1314 and in 2016, and this time the COVID-19. So what happened was, when we saw what were the lung findings, or what were the ultrasound finding of both the patient, both the category of patients of pandemics, it was comparable. But this time what we had more portable ultrasound, we have more safer ultrasound, in the sense that the machines were not that bulky. There was ease of sterility was there. The probes could be made sterile again, or a probe cover used to come. The accessibility was there. The difference which was there in the use of ultrasound in both the situations was the imaging capability was quite good during this time, and there was this possibility of data sharing and the use of teleguidance and AI. So we had, at a remote center someone can do, and if that remote center is connected via Wi-Fi or with the internet, secondary at the secondary center, expert opinion can be taken. Now, when we talk about triaging, definitely any patient who comes to emergency department, and during COVID times, what we had was, if the patient was having mild clinical features like just a little bit of fever and cough or something, focus can be done during triage, and if
Ma'am,
the
we are
lung
still on
ultrasound.
prior pandemics. Is that okay?
Sorry,
Ma'am, the slide is still on prior pandemics.
I
So,
think the slide would change in a couple of seconds.
okay, done, ma'am. Yeah, ma'am, it's there.
Yeah, so I think there is some lag of 5 to 6 seconds.
Okay, done, no worries.
Yeah.
Thank you.
Yeah, so talking about triaging of the patient, when any patients comes in the emergency, and then to see where this patient would go, just giving an example of how during COVID it was done was, if patient had very mild features like only fever or a little bit of cough or sore throat, so definitely lung ultrasound can be done. And if it shows a normal lung sonography, there is no finding, the patient can be sent for quarantine according to the hospital guidelines and the government guidelines. But if patient is having severe or critical disease like shortness of breath is there, wheezing is there, or the saturation is falling, or also if ultrasound is showing, the lung ultrasound is showing some pleural line abnormalities or B line consolidation, that patient can be moved to the COVID unit or may require ICU. The same thing, the algorithm which can be incorporated is for ultrasound, with ultrasound, is definitely when we talk about anything, it has to be airway, breathing, circulation, and then we talk about D and E. So in airway, what we can judge is the endotracheal tube position with the ultrasound to position confirmation. In breathing, we can see whether there is unilateral or bilateral pleural line abnormalities. Is that lung sliding B line is present or not? Is there any subpleural consolidation or any pleural effusion is there? So these are the parameters which we would have to see when we are assessing for the lung ultrasound. We'll come on to each and every thing in our next slides. In circulation, when we are talking, it's you have to see the cardiac contractility, you have to see the IVC collapsibility or distensibility to check the volume status, and differentiation between CP versus ARDS, that is your cardiogenic pulmonary edema, and your acute ARDS. In ICU, the same algorithm can be integrated in the ICUs, that is focus algorithm of airway, breathing, circulation, plus monitoring the course of diseases. Like definitely if your patient is of cardiogenic pulmonary edema, patient has come with shortness of breath, and when you auscultated, there were a lot of grabs. You started on Lasix infusion, you started on an IV support, and then you did the lung ultrasound. In that, you would see a lot of confront B lines, and when the patient starts improving, there would be reduction in this confluence of B lines and the patient clinic. So the clinical parameter will correspond to the lung ultrasound finding. So definitely we are monitoring the course of disease also with the lung ultrasound. The fluid status assessment, like when you check the IVC in the emergency, a patient has come with hypovolemic shock, like patient was having a couple of loose motions and vomiting, and the patient is dehydrated. You have started fluids, you checked IVC, it was more than 50% compressible or collapsible, and then with proper fluid resuscitation, then when you measure again the IVC, you can comment on the fluid status assessment. Then definitely the most frequently which is done in the ICUs is the checking for the myocardial dysfunction, that is checking EF via doing a 2D echo.